George, you can answer this, is are there formulas for determining return on investment for
Typically,
new agents?
Typically not. We loosely look at value on a population basis as nothing more than outcome over cost. And if you speculate on a drug whose price is going up that dramatically, nothing changed about the drug. So theoretically, nothing changed in the outcome, right? I think we'd all agree. Same drug given over 3 years is the same drug. So the outcome is not going to change. If the cost went up 50%, then our value went down by that proportional amount. And it's a simple-minded way of looking at it, but it's a way that health plans look at what value do I get for these therapies. And you try to compare. If you get drug A that gets outcome A, you get drug B that gets outcome B, and clearly B is superior. If they cost the same, then we're going to want preferential, access to drug B. And you can get into all the permutations of that. But there are no really bean counters sitting there saying, well, I'm not going to invest in this drug unless I get this return. The science isn't there to do that.
But I mean, from the pharmaceutical company's point of view, because we want companies engaged in developing new agents for MS, right? And so they have to get a return on their investment, right? It has to be worth it for them to put up the hundreds of millions of dollars it takes
over
to bring,
$1 billion now.
Yeah, okay, $1 billion to bring a drug to market. Okay. How do we counterbalance that with these kind of changes, which don't necessarily make economic sense, right? Because the price at which you come out should be reflective of getting a return on your investment over, I don't know how many years to figure. That's why I'm asking if there's a formula for this.
So why did they go up?
So why did they go up? 20 years old. They have gotten their return on their investment many, many, many times over. The interesting part of why this went up was because a newer agent came out that set
So
the
instead
stage.
of reducing, it increased.
And we
They
thought it would.
came up. That's
because
really
it's not
bizarre.
what it costs to make, and it's not what the research, but it really is what the market will bear. But the interesting thing too is, I'm sort of curious as to how many of your patients, because you both see patients, are what we call fee-for-service or self-pay.
For the medicine or for seeing us?
For medicine.
They couldn't afford the
Almost-
medication?
Yeah,
And that's a problem.
almost none.
And that's a problem, isn't it? Because we're all paying for it.
But I'd like to know, what do you think is going to drive the prices down? Is this going to be generics? I mean, this can't continue. We have 10 approved agents. We have more that are coming down the pike. What's
It's a
going
great
to bring
question.
the price
Again,
down?
a question that we talk about a lot, and it really is going to be I think, and Gary, you're going to have to really speak for yourself here, obviously, but I think it's going to be transparency. And I think when people can really see what the therapies cost, in the ACA rules, comparative effectiveness should be, and again, we talked all about the data issues, but there is a comparative effectiveness that they want to look at therapies versus other therapies. There's some government bodies that are going to be non-biased that are looking at it. But I do believe that it's going to be transparency and education of the member, of the physician, the healthcare community. I think that will help people understand very much so.
How about allowing Medicare to negotiate?
Slippery slope. I mean, Medicare to negotiate and price controls become, somewhat intertwined. And on one hand, that's what the EU does, right? They negotiate a price. And I think just in the news last week, India took dozens of drugs, if not hundreds of them, and renegotiated a price unilaterally. They just said, this is what we're paying for them. That certainly would help with the cost aspect of things, but I think from an innovation aspect, that could have disastrous consequences in a price control world. So I'm not sure, that's the best way to go either. I like Leslie's idea of transparency. If the consumer gets engaged in the value of the services being provided for them. Now, we've tried to do it by engaging them in increased out-of-pocket costs, but that has limited success, because if you increase the out-of-pocket cost above a certain threshold, they can't afford the medicine anymore, any more than they can afford it at list price. So that can't work alone. Generic GA will be along. That could bend the cost curve a little bit in the MS, because that'll be a true generic. GA is not a biotech drug, so.
Well, it sort of is.
It'll
It's
be
more
looked
a
at.
biosimilar than it is a hydrochlorothiazide.
Well, agreed, but I know that the FDA is probably going to look at that as a true generic as opposed to a biosimilar.
Well, they have 3 generics that are in front of them, but
yeah.
some
My
of them have
guess
been in
is they're
front
going
for
to
a
want
couple years.
some
They may want
therapeutic
some
outcome.
clinical data.
Yeah.
At least.
Definitely.
Yeah, now the interferons, it's going to be true biosimilars if someone produces one of them, and we don't even have the biosimilar process in the U.S. defined yet, so that's still open.
So I don't see a consumer groundswell for this. Every patient I talk to about getting on therapy, I say, do you have a drug plan? I said, because no matter what I give you, it's going to be really, really expensive. And for them, it's somewhat shockingly expensive, but most of them are covered.
Yeah.
The ones that give us the most difficulty and the most lost sleep are the ones that the working poor, the ones that don't have enough coverage, that are don't have Medicaid, they don't have this way to get a Medicare, trying to get them drug, and that drives us crazy because it's extremely difficult. The companies have some programs which we're grateful for, but in the end, we're still back to these very high prices.
I don't think any of us have a good answer, do we? Some of these working poor will be insured under the exchanges, and Leslie has experience with that in Massachusetts. But the exchanges aren't going to solve the problem either, because the working poor are probably not going to be able to buy a platinum plan. They're going to buy a bronze or a silver plan, and there's still going to be substantial out-of-pocket costs.
That's the worry.